Hey, welcome everybody. My name's Sophie Scott. I'm the medical reporter for ABC and I'm going to be your host for this webinar. So today we're going to be talking about breast implant associated anaplastic large cell lymphoma. It's a bit of a mouthful, so we're going to shorten that to ALCL. So that's what we're going to be talking about today. The idea is that everyone will get good information and be up to date about the latest information about ALCL. Before we introduce the panel, we've had lots of questions already. They're all on this iPad and I'll aim to get through as many of the questions as we can. So if you still want to ask questions, please do so and we'll aim to get through as many as we can. The briefing will also be recorded and you can play it back later. So there'll be a link posted on the TGA website. We would love you to share this webinar with as many people as possible on social media. If you're on Instagram or Twitter and you'd like to follow me, my handle is @SophieScott and the number 2. So I'll be posting the link and the recording when it's up. So without further ado, I'd like to introduce our panel. We have Professor Anna Ndaba, plastic surgeon from Macquarie University, Dr. Anna Locke-Wilkinson, a plastic surgeon from Queensland, Dr. Sanjay Warrior, a breast surgeon who works at Lifehouse. Monique Bock is our consumer representative and Miranda Laumann from the Therapeutic Goods Administration. So thank you all for being here and taking time to do this really important panel. I will just mention briefly that the advice and the information that you'll be hearing in this discussion is general in nature, and if you have any specific concerns, we do suggest that you discuss that with your own personal physician. But you'll be hearing lots of great stuff today. So before we get underway, let's just briefly take us through a couple of stats about breast implants. So I might start with Dr. Deva. So talk us through breast implants. You know, when were they introduced in Australia? What do we and what are they generally used for?
Sure. So breast implants have been around for some time, introduced first in the 1960s, and they're used for either cosmetic enlargement of the breast or reconstruction after women have had cancer.
And that'll be the discussion today. This webinar will be for that second group of women. Obviously, both can listen, but we'll be particularly addressing women who've had a reconstruction.
Absolutely. Implants can vary in terms of what's on the outside, so broadly speaking, rough textured versus smooth, what's on the inside, which is whether that's saline or silicone gel, and the way they're shaped, whether they're round or teardrop. And they're highly regulated, so you can see here that they sit on the top of all devices, in that the Class 3 devices, the benefit has to be balanced with risk, and we should hear more about that. It's very important for women to know that in Australia we've led the way with registries in breast implants. Around 20,000 Australian women a year choose to have a breast implant, and all of these women are encouraged to ensure that their device is placed on the ABDR. It tracks and monitors long-term safety and performance, and it's endorsed by all the societies, all the surgeons, all my colleagues, and by the TGA. It's a free service, so please ensure that if you choose a surgeon that they use the ABDR. And briefly about ALCL, our focus obviously is to talk about that. It was first reported back in '97, so once again, a long time. But it's really in the last decade that we've had a rise in number of cases, with 33 confirmed deaths from this worldwide. And currently, we know that there are at least 838 cases. And the reason we're here today is that Australia actually has a disproportionate number of these. We stand at 107 cases arising from women implanted in Australia as at 31st of January this year.
Okay, well, we will unpack some of the numbers and risk a bit further into the discussion. But I think we might just start off talking about, even before we get to women having implants, what considerations need to be taken into account for women who are having or thinking about augmentation after cancer treatment? Maybe we'll start with Dr. Locke-Wilkinson.
So there's a lot of different factors that go into what type of reconstruction you have, but particularly with implants, you know, whether you're going to have chemotherapy or radiotherapy is important, and that's sort of guided by our breast cancer surgeons and oncologists. Whether you're going to have a reconstruction straight away or delayed, again, there's a lot of factors that go into that. But, you know, the type of implant that you use, the timing of it, there's many, many factors. So it's really important to go to, you know, well-qualified surgeon. If you're not happy, to seek a second opinion. And really get all the information before you decide which path you're going to go on with your reconstruction.
So maybe Dr. Warrior, can you take us through what you would take a patient coming to you who's been diagnosed with breast cancer? What are the things they need to weigh up when they're thinking about either having a reconstruction? You know, what sort of things they need to think about?
So when we talk about with the diagnosis of breast cancer and it can be quite a complex time to be having a discussion about reconstruction. Traditionally, like Anna said, we used to do just delayed reconstructions. With time, what's happened is there's been an increased shift towards immediate reconstruction, which is trying to preserve the skin envelope, with the whole benefit of that being that you're preserving the skin. So really you're just replacing something in the middle, which will either be an implant or their own tissue. And ultimately, it is nice. There are certain types of breast cancers where we can actually start with chemo first. And if the patient already needs chemotherapy and it's part of their package, sometimes by giving the chemo, it takes that pressure away from making a decision immediately, and then they can look at their options and then proceed following that treatment or targeted treatments to immediate reconstruction. But the whole premise for us, why we moved away just from doing delayed reconstruction, was primarily what it looks like at the end.
So to get a better result.
Yeah, just aesthetically when they're looking in the mirror. And also not going through that phase where they may, from a quality of life indicator, where it's not just their survival outcomes, but it's also when they're looking in the mirror, how they feel. Yeah.
Are implants the only option if you're having a mastectomy, or Dr. Wilkinson?
No, not at all, actually. We've got some really good options to use your own tissue. And, it's important that you get at least offered all the things that are on the reconstructive menu and at least have the chance to talk about that. And you may or may not be suitable to use your own tissue for different reasons, but the option is certainly there, and there's plenty of really well-qualified surgeons in Australia that can talk to you about that, the pros and cons versus the implants, the timing, again, whether you have delayed or immediate. And I think important that, if you're not suitable for an immediate recon, you can still get some really good results with a delayed reconstruction. And if that's more suitable in terms of your cancer timing and that, then, that's definitely, it's better to go that way. So
just if women do decide to go down the implant road, what considerations should they take into account when deciding on what type of implant that they might have? What do they need to weigh up? Who wants to? Dr. Daver?
Well, I think broadly speaking, implants come in all different shapes and sizes and surfaces. Australia, as a rule, has always tended to prefer textured implants, and that's kind of the discussion, why we're here today, because textured implants have been linked more commonly with this with ALCL. So in terms of what type of implant really depends on the anatomy of the patient, depends on the shape of the other breast, so we're trying to match as much their normal anatomy with a reconstructed anatomy. And then, as we've said many times, that's the time where if you're choosing an implant reconstruction, it's really, really important that you get all the facts and you're allowed time to digest them, and perhaps at least 2 occasions, if there is time, pending a cancer treatment, to go through these with your treating doctor.
And we might just go through the different grades of breast implants and the risk that correlates with those different grades. So can you take us through that?
So broadly speaking, we have the differences in grade related to the roughness and the surface area of the implant, and we grade them 1, 2, 3 and 4. And it's the grade 3 and 4 implants that are rougher and have a higher surface area, and they're the ones that we now know through scientific evidence have a higher risk of getting anaplastic large cell lymphoma.
And are you able to quantify when you look at the numbers, what is the risk in terms of one in how many cases are at risk of getting ALCL?
So roughly for a grade 4 textured implant, again, depends on whether you've had one implant or multiple, but it's anywhere between 1 in 1,900 to 1 in 2,500, so it's the highest. And then some of the lowest surface areas textures, so the grade 2s will be, between 1 in 15 to 36,000. So it's quite different. It is statistically significantly different.
And so some of the textured implants have been recalled and they're not on the market anymore. And I guess this might be a question for Miranda Lauman from the TGA. Can you take us through, just in very broad terms, the ones that have been recalled?
Sure. So there's 8 products that have been recalled. It represents about 6% of the breast implants used in Australia using the 2018 data as a bit of a measure. So it is a smaller section of the market. 7 of those products are the macro-textured products, and 1 is a micro-textured product. And that's been done on the basis of clinical evidence provided by the manufacturers, of laboratory testing undertaken by the TGA, and also looking directly at the statistical correlation between individual implants and cases of ALCL in Australia, as well as where the same devices are produced by the same manufacturing or have the same surface texture as those that are linked directly with ALCL.
And I guess a question that the audience might have is if the risk goes up compared to how textured the implants are, why aren't all the most textured implants or all the textured ones off the market?
So I think part of the assessment that it needed to be made was looking at the risk versus the benefit of devices, and there are certainly benefits associated with textured implants, particularly in a reconstruction context. More textured implants can prevent movement and are linked with less incidence of capsular contracture. And so ensuring that there are options for women who need to undertake reconstructive surgery and wish to have an implant was also an important part. So the TGA's role is to ensure safety and quality, but also to ensure that Australians have access to quality medical devices. So it is a balancing act.
And I just might get one of our physicians to comment on that as well, because from the outside, someone might say, well, if the textured implants are more risky, why don't we just not use them? What are the benefits from still using the textured implants from an outcomes point of view and how they look? Like, what are the reasons that some doctors and patients might decide to still keep to use them?
Yeah, so with regards to when we're talking about reconstruction, we've talked about removing all the breast tissue, and with that, there'll be variation in anatomy of the body, and having the ability to have varying devices that provide sort of mimicking
More natural look
is an advantage for potentially for patients. So there will be patients that are appropriate for round devices, which tend to be the grade 1 devices. But it's nice to have the option of potentially other devices. And on top of that, we also use temporising expanders in certain cases, and that provides options where we can not necessarily get the complete reconstruction right at the first setting, but allows us to grade our results to the point where we then do an exchange down the track.
Right.
So what that means is that end of the day, we're giving that quality of life result for the patient.
Yes, Dr. Daver?
Can I just add, so broadly speaking, the grade 1 devices are smooth, so there's no stickiness, whereas the grades 3s and 4s stick. So if you're recommending a device, for whatever reason, you want to minimise long-term reoperation as well. So the times where we would recommend a textured device, and that's why it's not so simple to say get rid of texture, you might be committing this woman to having multiple revision surgeries. So the factor here is time. We can make a decision today that might say ALCL's gone, we're just going to use a grade 1 device, but we might be inadvertently then subjecting our patient to multiple revision operations. So this is the balancing
It's complicated, isn't it? So I was just going to go to Monique. So what are the sort of, it is complicated for women then to weigh up all these different factors. What are they saying to you when they
It is,
talk
I
to
guess
you?
the feedback I'm getting is that they've already had breast cancer. They don't really want to have another risk of another cancer. So why even consider that? The ones that have had the BIA-ALCL after having breast cancer, had they known there was a risk, they wouldn't have taken it.
So it's difficult then for them to weigh up all this different
It is,
information.
and I think they're emotional. There's a lot going on as well, and are they going to be making an informed decision at the time as well?
So we can talk about that. Let's talk about the idea of informed and educated consent. Did you want to add something, Dr.
I think that's where it's important to actually know what other options are out there, and patients aren't always told, and that can sometimes come down to financial reasons. But if you're not happy, go and seek a second opinion, because there are some fantastic other options. You may or may not be suitable, but getting onto informed consent, if you're informed and educated about all the choices, then you can weigh up the risk and benefit and make the right choice for you. And just because you have one type of reconstruction doesn't mean that that precludes a different type of reconstruction down the track. So, you know, again, staying in touch with your surgeons and, you know, because your body changes over time too, or, you know, if you choose to have an implant, you know, maybe years down the track you might want to get that changed for your own tissue or something. So, yeah, know what your options are. It's, you know, consumer choice is really important.
Monique?
What we did discuss about perhaps in future that someone brings along a support person with them as well, so that they've got someone there that's going to be listening and taking in everything, so that they're not on their own. Helps them to be a little bit more informed.
And Miranda, what's the TGA doing and the regulators in terms of improving informed consent, or making sure that patients as much as possible know what their options are and know what they're getting in for?
So an important part coming out of the review was not only suspending devices, but putting a range of conditions on devices that remain available in Australia. And they've been aimed at educating the regulator. So there are some reporting conditions that have been put on every breast device available in Australia. There are also really important measures around informing consumers and informing practitioners. So enhanced information pamphlets for practitioners, and a patient information leaflet that's specifically targeted at a patient level. It's accessible language, accessible information to give information about that device so that people can have better conversations, ask better questions and keep informed. And that condition comes into effect today on Valentine's Day.
Oh, that's good.
There's also some really good information on reconstruction. The Cancer Council has one on breast implant. They've got little booklets that you can actually go and get a rough idea of different options. So.
That's great. So, yes, Dr.
I was
Dable?
going to say, is having treated some women who've had this double breast cancer and then ALCL, I really want to echo your words, Monique, because there's a lot going on, isn't there? So I think the struggle.
You've just got,
the struggle is how do we create a framework where enough space and time when there are big decisions to be made, often in a short space of time. So I don't have. I mean, you two do way more reconstructions than I do, so I'd be really interested to hear, if you had thoughts on how to do that.
For us, it's not just the recon, it's everything, because when you talk about breast cancer and you're diagnosed with breast cancer, it's not just the surgery, it might be, you may need chemotherapy. It's just making sure that the treating team, everyone sees the person before they necessarily have an operation, and it's just not a captain's call per se. And it's easy, in the past, it would be easy to potentially feed off the anxiety of the patient and that drive
decision making.
Whereas we know what is important when it comes to cancer treatments, whether it's recon or not, is having the time to make sure you're getting the right options available. So where that tends to work, it's a lot easier when you're in a larger centre, obviously, where you've got a multidisciplinary group and where there is good communication between specialists, because then it's easy. You can phone your friend at meeting another specialist and get the patient to see someone else in a
Within
timely
that group,
manner and then come back and see you again. But what I've found with time, it's very important that they see multiple people before they have surgery.
Yeah, so you've got your radiation oncologist, your breast surgeon, your plastic surgeon. So, if you don't feel that you've got all the information, make sure that you say, I want to see that person.
So let's take a patient, for example, that they have decided to have implants, they've decided to go down that track, and they might be concerned that they might be having some issues. What are the symptoms that women need to be looking out for? What are the classic symptoms that might suggest that it might be ALCL and they need to get further investigated?
So the majority of patients present with a spontaneous seroma, so a reasonable size collection of fluid around an implant. And it usually happens quite a few years after the implant is put in. So on average, every sort of after 6 to 8 years is the average time, but it can occur anywhere between sort of 3 to 14 years or even longer. And we're still collecting data on that, but as it stands, 6 to 8 years after the implant's been put in, you get a large swollen breast for no particular reason.
So no trauma or anything else that would have precipitated it?
Very rarely you can present with a mass. That's the other sign. But generally, most patients present with sort of a collection of fluid around the implant when it's generally painless.
Okay, and then just step us through if that's the case and a woman does have symptoms. What's the framework in terms of the treatment that they should get in terms of like the diagnosis? What are the steps that need to happen so that you can make sure you are picking up anything if it's there or excluding other things?
So I think, as Anna said, the majority of women present with swelling, and the swelling is due to fluid between the implant and the capsule, which is the tissue around that. So the first step would be an ultrasound test where the fluid is drawn and analysed, and that will give you the diagnosis. And that's by far the majority of cases. And then you need to be worked up with a CT, PET scan and MRI scan potentially, and then for surgery. So that's kind of the path which most women would go through.
And we'll talk about that. Monique, did you have something to add there?
How much fluid do you need where there's patients that don't have enough fluid and they don't get tested properly because there's not enough fluid?
Yeah, that's a good question. So we've estimated, and this is based on advice from the ultrasonographers, around 50 cc's is usually enough. And the issue here is sampling that fluid without damaging the implant. You can sometimes do it on lower volumes as long as the ultrasonographer is skilled and comfortable enough to draw that fluid out.
Yeah, and so sometimes you can get false negatives as well?
It's not so much a false negative. If you haven't sampled enough of the fluid, you may not be sampling the whole area and you might miss it. But generally speaking, the earlier stages of the disease is not going to go away. So the fluid will reaccumulate, patients will represent in a few months' time with more swelling, and at that point the diagnosis is made.
So let's just backtrack for 1 second. What if you have and we've had a couple of questions, if a woman has had implants but no symptoms, and yet they might be concerned hearing about ALCL and the risk. What's the medical advice and then also the regulator advice about whether they should have the implants out if they're concerned? These are for women without any symptoms.
So there's no recommendation to remove the implants if you're asymptomatic. Removing the implants, when you don't have symptoms, it also comes with, a certain risk of doing that. So we don't recommend taking them out, but we do recommend, having good GP, continuing to see your surgeon that, has put the implants in. And if they've retired or moved on, then get your GP to refer you to another surgeon so that you can...
So you make sure you've got that ongoing care.
Yeah, it's really important. That's, if patients getting surgery done overseas, they don't necessarily have that option for follow-up. So it's, ask your surgeon what follow-up, you're going to provide, because it's not just doing the operation. You actually need to have some ongoing maintenance and care. So you need access to that.
And so from a regulatory point of view, Miranda, the TGA doesn't recommend that women who don't have symptoms get the implants out. Is that correct?
Yeah, no, that's exactly consistent with the advice we're getting from our expert working group, that in the absence of symptoms, there shouldn't be removal, but certainly people should be trying to get informed, understanding what the symptoms are, understanding their own breasts and self-examination, as well as engaging with their health professionals so that you know what's going on and you have a really good point of care.
Monique?
There are also patients that don't even know what type of implants they have. How can they find out?
Yeah, that's a good question. So say, for example, if a woman doesn't know, where would they, which is probably less likely if they've had as a result of a reconstruction, but there may be some who don't know what type. Where can they go to find that information out, Dr. Deva?
So look, this does happen from time to time. So the first thing I say to them is, are you sure you don't have any bits of paper at home that you've collected over the years? And sure enough, more often than not, there's a card with the implant sticker on that they didn't know they had. So that's a good port of call. If the surgeon's retired or the clinic's closed and you can't go to that avenue, then the hospital where you had the implant put in is another really good place to look. Hospitals keep records a bit longer than the statutory 7 years. So
even if they're overseas or some of the
overseas
clinics?
is a bit more difficult,
Yeah.
but contacting the hospital where you had the implants, they might have some record of your surgery. And then the third, which is an increasingly great way to know exactly what implant you have, is the other registries. So the ABDR since 2015, we think, has collected and increasingly collecting up to 90% of implants that are going in now today. And so ringing up and giving your details might allow you to access the information. And prior to that, there was a breast implant register, the BIR, and that's also accessible through the internet. And once again, you can contact them. So there's many ways you can find out.
One of the questions that we've had, which I think is worth putting to the panel, is for women who've had implants as part of a reconstruction, why is it okay for women not to have these implants that have been taken off the market, the recalled ones now, but that they should keep their implants. So how, and that would, I would imagine, cause some anxiety if they're hearing, oh, these implants have now been recalled, yet they've got them and they have to necessarily, they've got to keep them. So what would you say to those
patients? They've been recalled to try and prevent future cases, but just because you have one of those implants doesn't mean that you are going to get ALCL. And again, it comes down to the risk of actually removing that implant isn't zero either. So if there's no hard evidence of symptoms, then that's not the recommendation to go through sort of unnecessary surgery. But it is really important just to keep, the monitoring up and that.
And another question is, if you've had implants for a reconstruction, are you covered by Medicare for removal or replacements?
For reconstruction, yes, you are.
Yeah, that's.
But in the public hospital, the replacement for non-reconstructive patients isn't necessary. But for reconstruction, there is.
It is, okay. So we might just go to a couple of questions from that have come through. So a question from Jennifer. She's asking, how should a patient respond to a surgeon who says that extensive capsule sampling isn't necessary because the surgeon or pathologist can see where the disease is by looking at it? Is that correct, or what should happen if someone is told that?
Yeah.
I would get a second opinion. That's not accurate.
Yeah.
Firstly, it depends what the scenario is, but if you've got a thickened capsule and you're symptomatic with it and you're looking at firstly, and you've had fluid tested, but you've still got a thickened capsule, you should be seeing someone who, because ideally, to really know what's happening with the capsule, you'd likely remove it.
There's another question here as well from Amy. What's the current opinion from the panel on textured tissue expanders? Should we be performing complete capsulectomies at the time of tissue expander to implant exchange to negate that risk? It's quite technical, but I think it's
a very good question.
Yeah, so
I don't think we really have the evidence on that yet.
We often use the capsule, don't we?
Yeah.
So the capsule is a way of
Yeah.
stabilising the implant. So if you were to remove all that capsule, you'd be starting from scratch. And
That's the thing, right?
And
It's
so I don't
particularly
know.
interesting
That's a
when
very
we-
good question.
Yeah.
I think the risk is generally low. It's not zero when it comes to, but you're removing the contact device. By doing that, you're potentially reducing the risk, and the expander doesn't stay in for a long period of time. But what Anna was saying, ultimately, it's the pros and cons when it comes to the aesthetics, because the capsule acts as a potential interface for lipofilling, potentially, and also just providing an area where we can place the implant easily without rotation.
So we've talked about a little bit about the steps of what women would go through if they had symptoms and to be picked up. One of the questions that often is asked that we'd like to get the panel to answer is, can you test for ALCL with a blood test?
No.
And why can't you test it with a blood test as you can with some other conditions?
Because the disease is in the fluid around the implant or the capsule in the implant itself, or for those rare cases that present with a mass within the mass. So it's not actually hematogenously spread,
In its
at least
early-
at that early stage.
Is that something that you get asked quite a bit about the blood test?
Quite often. And I think they get a bit confused because they think it's a little bit of a breast cancer. They don't understand the difference, and they think that they can go and get a blood
Yeah.
test.
So there's a lot of cancers that aren't picked up on a blood test.
Yeah.
Breast
Also,
cancer.
the ones that have the swollen lymph nodes and the rashes. We get a lot of questions. What do we do about that?
Yeah, so what would you suggest if a woman has implants and they have, say, for example, swollen lymph nodes and they're feeling tired? Is that enough to get a biopsy, or what should that woman do? Dr. Warrior?
Yeah, I think ultimately they need a clinical assessment when they have symptoms, and that includes not just the implant, it includes the breast, including the lymph nodes, and part of that assessment would include an ultrasound of the axilla and also an MRI potentially. And then it depends what's causing the swelling. Is it relating to the implant, or is it relating to other things that have come from the breast tissue? And it's really, then you would then escalate from there. But they should definitely be seeing a specialist with it.
And so, Monique, what are you finding? How anxious are women in this particular group of women, the women who've had cancer and a reconstruction? and now with these recalled implants, how anxious are they that they might be affected, and what do you do to reassure them and make sure they get access to good information?
Well, I guess, I mean, they're pretty scared. It's pretty terrifying having, had one round of cancer already, and then they've got these, textured implants in. It's just important. I mean, I just tell them that they've just got to get followed up with their doctors and make sure if they're not happy with their doctor that they need to go to another doctor. But that's why I guess I think, I'm questioning why are we putting textured implants into people that have had reconstruction? They're probably the last person that would want to have another cancer diagnosis.
Is that something that you would talk to patients about if they've had a cancer diagnosis, they're having a reconstruction, that you might say to them, you do need to weigh up this risk So what would you say to them?
Yeah, I think it comes back, it's sort of, Monique's question ties in with what Anand was saying earlier when it comes to ultimately any sort of discussion about a surgical option. It's really difficult to do it with one consultation. It needs to take, it's difficult because these patients are going through a diagnosis where often their feeling is that the quicker you get to the operating theatre is going to impact the way that, what sort of result they get in terms of life expectancy, which is not the case often. So it's very important, I think, that the framework's there for patients that are diagnosed with breast cancer, that they're having time to understand the risks and pros and cons of not just implants, but other treatments, so that they're doing the right treatment for them.
And we can give you the numbers, if you come with questions, and when I consent patients, I will tell them what the numbers are for a particular type of implant. So as the scientific data stands today, this is your risk of getting, ALCL, and a number. And then that's then for the patient, because they're educated, then they can weigh up whether that risk is something that they're willing to take or not. Because it is, for some types of implants, it is quite small. But if you're that patient that doesn't want that minute percent, then that it's your choice.
Can I say there's actually quite a variation in acceptance of risk, and it's not for us to make that decision, it's the patient's decision. So you see some patients who you give them the number and they go, fine, okay, I'll take those odds. Others, I'm not going to take those odds. But that's not the physician's decision, that's the patient's decision. So we need to be very clear on and also that risk weighed with the risk of other things happening. So the risk of ALCL might be X, but your risk of reoperation might be, every 2 or 3 years.
That's a question here that we've had from someone saying, Kathy asking for reconstruction patients, why isn't capsular contraction discussed more often? Because she's a cancer survivor, had a reconstruction. It was discussed briefly, but she said the true statistics of it occurring, she felt it wasn't sort of explained to her that it was, an issue. So is that obviously something you need to factor in with patients as well?
Absolutely. Yeah. Like I think when you talk about implants, and particularly in the setting of radiotherapy, we are going to have a rate of capsular contracture. It is important that women are aware of potential, not just short-term risks outside of ALCL, but also long-term sequelae of having a device. And ultimately, it's really hard to do it in one consultation for the patient who's diagnosed with breast cancer to absorb everything at that one consultation. Ultimately, often they will believe what the person they see in front of them tells them. They really are trusting the person in front of them to give them the appropriate advice, and with that as well, hopefully consenting them on what one in a relatively important but relatively low risk of ALCL. So it is quite a complex area at that time. I do think that it is very important when we think about that it's not just a one consultation. These patients, when they're looking at reconstruction.
Yeah, exactly. I think it's important to, if it's particularly in patients that are struggling with the decision making, because it's very overwhelming. I think when you get a diagnosis of breast cancer and then you get bombarded with all this information, about the cancer stuff, the reconstruction. Well, the most important thing is to get the cancer treated. When you have your reconstruction, whether you have
so it sort of needs to be seen under that lens of that, and so priority.
Yeah, so you can have time, and even if you're suitable for an immediate, if you're not in that right headspace, that's fine. We can deal with that down the track. The cancer's the most important thing, but go away, think about it. Bring a support person, write down your questions when you get home, and because you're not going to remember everything. And when you come back to see the doctor, people often then, it's a bit of a deer in headlights sometimes. They might forget. So if you've got things written down, go for your second consultation. You've had time to think.
And taking someone with you is a really good piece of advice as well. Someone there who's just there to listen and write down the information that the physician's saying.
Yeah.
So that you can, as the patient, you can just listen, but someone else is actually writing it all down. And, we've got another question here from Lisa. She says she's 56. She chose a double mastectomy and a reconstruction to lessen the increasing risk of cancer. But she's small-breasted. What risks are there to explanting to the nerve blood supply, and also is a fat transfer? What benefit would that be? So they're quite technical questions, but what advice would the panel have?
What was the first part of that? Just with the...
She wanted to know, she's saying she's small-breasted. What risks are there in explanting to nerve and blood supply? What risks are there to the nipples and the breast tissue for taking the implant out?
Generally, once you're explanting, it's actually less than at the original operation. Okay. And then, fat transfer is one option for using your own tissue, but again, you've got to have enough fat. So some women aren't, suitable for that. But there's different options. There's quite a few different options. Some of them are more complicated than others, but important that you go and actually ask those questions and see what your options are.
Okay. There's another. We've got lots of questions coming in, which is good. One question is, if a woman does decide to have surgery, can you explain the difference between en bloc and capsulectomy? Can one of the panel explain that for us? Maybe.
Yeah. So really, an en bloc resection is a cancer principle. Generally, when we talk about, and ultimately it stems from other cancers where we take the tumour rather than cutting it, take it in entirety with a margin. However, ultimately in the setting of a capsulectomy, when we talk about an en bloc capsulectomy, which is the human tissue's reaction to the implant, ultimately it comes with its own risks, I think. So there'll be patients where it's relatively straightforward to take the capsule. If it's on top of the muscle, it's often easier. But if it's underneath the muscle, the posterior or lower level of the capsule will be sitting on the ribs, and it comes with its own risk. So you comparatively, for someone who's not got a proven anaplastic large cell lymphoma, where they're doing it for prophylactic or for preventative reasons, ultimately performing that surgery they need to be aware that it comes with significant risks, and you're balancing that versus potentially not a lot of benefit, I would think.
Right. Yeah. And Monique, with the women that you speak to, what are most of the women that contact you, what are they having?
With regards to I think a bit of both. And I think the questions that they say are that, how do I know I've had all my capsules removed? I've had explant and I've had textured implants. And they don't know. I
think you'd really hope that the person that's treating you is honest and they're being completely... But what some people have been doing is they've been asking for photos of the actual capsule, and
so
also...
they want to actually see evidence that it's there.
And it's probably a reflection of, and these guys will agree, a reflection of mistrust in the medical community from patients. So that they want proof that the surgeon is saying something, they're doing what they're saying, essentially.
That is sad, actually, in some ways, isn't it?
But there is also, though, that the ones that they've had the explant and then the surgeons have said, I couldn't get all the capsule out as well.
I would, at least the surgeon's at least been honest, which is a positive there.
Because that was a question. It says some women have said their surgeon recommends removing the implants but not the capsule, saying the body will absorb it. Is that okay or not okay? Or
So I think, as Sanjay says, it's important to be honest with the patient. So I think in the setting of ALCL, it's absolutely critical that the implant and the capsule are removed in its entirety. I mean, we have had recurrences of the cancer when bits have been left behind. So the stakes are very high there, and you would hope that anyone undertaking that surgery is absolutely committed to doing that. If they're not, they're not properly treating the cancer.
And just to interrupt for a second, but if someone's doing a known ALCL case and they're excising, they should be going to a specialist centre.
Yeah,
Someone who's
absolutely.
doing...
Yeah, and often we
cases.
actually do cases combined, right?
Yeah.
But then let's move away from ALCL, and so you might have someone with a capsular contracture, or you might have someone with another non-cancerous problem around an implant. That's where I think you need to be honest with the patient. I will try and take this capsule out, but in the setting, as Dr. Warrior says, where the capsule is very tightly stuck to your ribs, then my ability to take that out is going to cause a huge risk of bleeding, puncture of your lung, etc. And you can list these complications. They're not minor. So it's really a balance between, benefit and risk. So when you move away from the cancer sphere, the term en bloc is not, I don't think is quite appropriate. So I talk about a complete capsulectomy or a partial capsulectomy in those benign cases. And I'm very honest with the patients. I will do 100% my effort to try and get it all out, but if I can't get it out, there'll be a reason. And the reason is to keep you safe.
And what you talked about some distrust in the medical profession with surgeons, with maybe patients wanting photos to make sure that it's all out. What should women do if they don't have a good relationship with their surgeon and they don't feel supported? Where can they go for help? What should they do?
So you can always get a second opinion, get a good GP, get re-referred to someone that you are happy with, because there's a lot of factors that go into it. Someone technically might be good, but you may not gel with them well on a personality point, find that you can approach them and talk to them. So, go and find someone that you can go and see comfortably, feel like you're being heard.
Monique?
I guess I get a lot of questions is that the people, they don't know who to go to. The surgeons are too expensive and they can't afford it. So that there's a lot of desperate women out there that want alternatives. When are we going to have more clinics opened up in the country and, more support for people? There's not enough surgeons to go around that aren't going to charge the earth and look at it as a money-making exercise.
So that is a factor as well for women, isn't it, to weigh up whether they can afford to have the treatment that they need and if they need to have them out. What do we need to do?
Affordability is a problem across healthcare. I mean, we've spoken about this, Sophie. I think that in the setting of breast implants, you've got to remember that we're talking about recon here, and that a lot of these women are older, they've got more means, they've got access to the health funds, which will cover some of the revision surgery, but there are also a lot of women who don't. So I think that capacity is a big issue. There are only a limited number of surgeons, and we're all getting busy and full with women wanting their implants assessed. So my real solution for this is to upskill primary care, to get general practice much more aware of implants, breast implants, complications. We're working on a number of assets, publications, education, so that every GP, has got some level of awareness and some more than others. And so that's the only way we're going to deal with this. And people who really have a problem can then be sent quickly and effectively and affordably to a surgical service.
Yeah, Monique?
It would also be good to have a document that people could take with them, when they've got some symptoms or some issues. If we could standardise something and have something like they, have the NCCN guidelines in America, or have something where people can also take and the surgeons are going to listen to it and follow the guidelines.
And is that something that the TGA could develop, or what would be of use to patients, do you think, Monique? So what would you want on that list?
Oh, something that we can hand out, because a lot of doctors don't even understand what this is. It's taking a long time, for GPs to understand that it's not a breast cancer, that it's a totally different type of cancer.
And certainly that's that area of both health professional education as well as consumer education is something that that we're firmly working on. We've been out of the consumer workshops that we've had already and that we'll be continuing to have into the new year, looking at those real questions that women have and ensuring that we're reaching back into the health community to ensure that that information is available so that people can respond to those questions. I think one of the challenges, of course, is that the healthcare network, there are lots of people who have a little bit of skin in the game, and coming together is a really important part of moving forward, and we're really starting to see that through both our work with health professionals and our work with the states and territories, our work with consumers, and also partnering with the Commission on Safety and Quality in Healthcare. But it does require a number of people to come to the table to keep moving forward.
Dr. Lock-Wilkinson, did you have something you want to add there?
Oh, no, just listening.
Okay, so we've got a couple of sort of fairly technical questions, but I think for the audience for this particular webinar, they'll probably want to hear answers. So one of the questions is, there's been several articles on this to indicate that an excisional biopsy rather than a needle biopsy is necessary to rule out ALCL in a suspicious lymph node. Does the panel agree with that or not?
That's
You can
that's
say
a
no.
difficult one.
Area.
I think that the diagnostic capability of a needle versus an open biopsy is probably, particularly with ALCL, which is quite uncommon.
Yeah.
Generally speaking, seroma disease, like the fluid disease, it's the fluid test.
So you need the fluid, yeah.
In the less common situation where a mass has developed, it's not usually a lymph node, it's usually a mass attached to the capsule or a mass, within other parts of the body. And that's where, in my experience, and in a few patients that I've treated, a needle biopsy would be sufficient in order to get the diagnosis. Now, if the needle biopsy came back 50-50, you might move to an open.
Okay.
So jumping to the most, invasive way of making a diagnosis is not always the best way.
No.
Right.
Okay, that's good. Now, another question was, if a woman has an enlarged lymph node and is told that it could be to silicon or it could be a reaction to the implant, what type of testing or follow-up would you recommend that she insist on to make sure that ALCL is not dismissed down the track?
I think it's important to also realise when it comes to lymph node enlargement that it's not just ALCL. There are things like silicon granulomas that form within the lymph nodes from leaking implants, potentially, and ultimately what we tend to do is we would biopsy one to prove that that's what it is, and you could start with ultrasound, and the option is there for MRI as well, and regular surveillance. But often moving towards anything that's operative comes with its own risks.
Yes,
So we
you
tend to
want to
leave them alone.
I think you've got to marry it up with your clinical history too, because there's many reasons your lymph nodes can be enlarged. And so, doing a thorough history examination, that's really important. I think that's where our GPs will be really valuable as well.
Another question we've had is about symptoms of a late onset seroma. So will a woman with a late onset delayed seroma always notice a change in the breast, or can it sometimes be only detected with imaging?
Generally, for ALCL, the seroma is large enough for us to have a clinical suspicion. So, if you went out and screened everyone with implants, you find that, there often is a little bit of some very small amount of fluid, but it becomes significant when it's a larger volume, and you tend to see that clinically.
And I think we talked about this in the earlier webinar, but what sort of, how much fluid do you need to be able to test properly for ALCL?
It's often about 50
mils.
50 mils.
So that's quite a lot. So it's usual for women to have some fluid, isn't it?
Yeah, it's
very, very small amount. Yeah.
It's common to have a rim of fluid. Where there is, a little bit more fluid, if possible, we would recommend, if it's 50 mils, aspiration, but otherwise you could always follow up with a progress ultrasound to see whether it's stable or not.
Then there's a couple of other questions about symptoms. Will a woman who's got the late onset seroma always have a skin that's red, or would she have any pain, anything like that?
No, generally not, no.
And other things like a change in the breast size, asymmetry, I think we talked earlier about, often just presents in one breast rather than both. Are they the sort of things that you would look for?
Yeah, so to date we haven't seen any cases where it's affected both breasts at the same time.
Not in Australia.
We have seen them in our group.
In other
overseas, yeah.
cases, yeah.
But generally, in most cases, it'll just be in one breast.
Yeah. But if you do notice a big change, so, we say, whether it's one side or two, go and see your treating surgeon.
I think it's also important if a woman's getting an implant for whatever indication, they're well informed as to what to look for. So it's not just swelling, because there are other things that can happen with implants: rippling, visibility, dropping of the breast, hardening, lumps, pain. These are all things that should prompt an assessment. Now, whether or not it's ALCL is unlikely, but being aware of these is important.
We do have a question on that says, is it true that not all women with ALCL present with the most common symptoms, like of a large delayed seroma? What about some other potential symptoms, such as a rash, itching, fatigue, fever, hardening of the scar capsule? How much are they red flags that you need to be looking into what's going on?
Yeah.
Well, I think if you have a symptom that's new, the simple way is to actually approach your GP and then potentially see, particularly in the setting of breast cancer, you'd be seeing a specialist who would assess it. And then you're both getting your own clinical assessment on it, but you're also getting a specialist to assess it. But then from there, commonly, redness is often a reflection of fluid underneath. I would think when it comes...
There have been reports of skin rashes
As
on
well,
and off
yeah.
as well. It's difficult because it's not uniform, and so skin rashes might be related to something else, or maybe to immune activation. So, I think the rule is that if anything changes, then there's a pathway to get clinically assessed quickly.
And Monique, so what are your patients, your women that come to talk to you or come to your page for advice? Have they noticed your symptoms like this? And generally, when they go to the doctor, are they getting good advice and help? Or
It varies. Some get good advice, some doctors tell them it's in their head and that it's not really anything to do with it. So I guess that's where it gets a bit confusing for them. You know, some will have a rash, some will have swollen lymph nodes, some have swelling. You know, there's a whole variety of issues going on. And I guess that they're scared too, because you can be diagnosed, you know, from the capsule, you know, without any symptoms. But
how often does that happen, though,
rare.
that you would be diagnosed without any symptoms?
Not very often. So I think less than 15% of women with ALCL present with, you know, non-swelling, whether it's a mass or something else, so or lymph nodes. So yes, I mean, I think be aware of your breast, be aware of your body, and if something doesn't feel quite right, get a medical assessment. And if you're not happy with that medical assessment, get another one.
Yeah, that's definitely good advice. I might just go back to you, Monique, in terms of what's being done to help women feel that they are being supported in this area. What else do you think needs to be done so that women have access to good information and good help that they need? What would you like to see?
I'd like to see more clinics around, and I'd like to see more documentation that people can take to their GP to inform themselves and stuff, information that we can hand out. But also more surgeons that aren't going to charge the earth for people and that are going to generally look after them. There's just not enough here.
And Miranda, you talked briefly, but what are you hoping to roll out to really make sure that patients are getting the help and the information that they need to address this?
So the TGA website has a breast information hub, which has a multi-tiered approach, so consumer-focused information, health professional-focused information. The most important thing about that hub is it is continually being updated. So I think it would be fair to say that we're all still learning about ALCL. There are things we know, there are things we don't know, and we're getting more cases which will help inform that. So keeping that up to date and pushing that information out is a really important thing. Within that hub recently, there have been some very specific information for health professionals that have been not only just put on the web, but pushed out directly to the colleges to engage with them to ensure that surgeons and practitioners have access to that information. And certainly there are opportunities for us to continue to partner with the broader health professionals like GPs to increase that level of information. But it is a bit of a moving feast, and keeping it up to date is therefore a really important focus.
Yeah, and there is this sort of ongoing data collection with that. So, you know, the more numbers we get, you know, the more information we have.
We had a question here about from Carmel, who's asking, so with the implants that have been recalled, who's notified about that? So say, are women notified, are surgeons notified, or is it up to the individual doctors and patients to go to the website and have a look? So what's being done in a proactive way to actually let people know that these are the ones that have been recalled?
So when the decision was made, an interim decision was made in July, and that information was made public. There is then an opportunity for manufacturers to provide additional information, and then a final decision was made in September. That information was broadcast quite broadly with a lot of media coverage, as well as on our internet, and the full list of all breast implants available in Australia at the moment and what regulatory action has been taken, whether they've been suspended or had conditions imposed, is available on the TGA website. But in addition to that, any of the suspended products were recalled from the shelves, which means that within a few weeks of the decision, those products were no longer available for use going forward. And then each company has various means of communication with surgeons and supplier lines to ensure that that is communicated, and they work hand in hand with the TGA to design and push out that communication.
So with those recalled implants, so would any doctors be using them now within, like, could they have old stock that they could still be using, or would it be your hope that they're not being used in Australia?
So our recall officers work closely to ensure that that product has been removed, to reduce that risk that there's potentially something sitting on the shelf that could be used.
I had been made aware of someone in particular that was still using them once they were recalled.
So that would be probably an exception, though, like using up old stock or whatever, so they can't get any new stock of these recalled implants, can they?
So there is a special access scheme that allows health professionals to, it's a general scheme that allows health professionals to access products that are not otherwise available in Australia.
But that's designed only for very specific instances,
That's right.
isn't it?
And it's designed where there is an individual patient who they think will benefit specifically from that device. So it's not to say, as a surgeon, I want to use this product more generally. It's a one-on-one basis, and there's a lot of assurance around that process and requirements for particularly heightened informed consent where the device is no longer available in Australia.
So we've only got about 3 minutes left. That's flown by yet again. It's flown by. I will, before we wrap up, I will say that if there are questions that haven't been answered by this webinar, that people can contact the Breast Cancer Network have a hotline that you can call in case there's any specific questions that we haven't had a chance to get to today. But I just wanted to go around to the whole panel and really just get you to, we've got a couple of minutes left, about 3 minutes. So just to wrap up, particularly for women who've had a reconstruction, who might be concerned about ALCL, what messages would you like them to take, and just to keep in mind with what we know now and sort of going forward?
So I think from the TGA's perspective, the best thing women can do is be informed and keep up to date with emerging knowledge, keep up to date with their own checks, their self-checks and their doctors. And I think from our perspective, the best thing we can do is continue to partner with health professionals and with affected women so that we're informing you. And this is a really great opportunity to continue that collaboration. So thank everyone who's come along today.
And Monique?
The same thing. I think patients need to be informed. I think they should also be, having, annual checkups. And if you're not happy with your surgeon or your doctor, go see someone else. But I also like to say a thank you to, for having the consumer representative be able to talk and you're finally, listening to us, and change is happening. It's happening slowly, but it's happening. So that's a good thing.
And what does it mean for you to be able to have an event like this or a webinar so that people can actually feel like they're getting the best information, the latest information from the people who are right in the centre of dealing with this issue?
Well, to know that you're listening to our questions and our problems and what's going on out there, because there's just so many people not knowing what to do, and we're not doctors or surgeons. We're just patients and patient advocates, and we don't have all the answers either. So, we do need the support. So thank you.
And Dr. Warrior?
Yeah, I think messaging this pretty similar, but be empowered. So have an idea, if you can, about what type of implant you have. And with that information, that will potentially, hopefully, de-escalate how you feel when you know, okay, this is a risk. And part of that is then the empowerment comes with the annual surveillance assessment, which would be with a health professional, hopefully a general practitioner, and then escalating from there. But there are varying ways to deal with risk. One way is removal, but there are other ways, and that includes assessment. And you've got to weigh the pros and cons when it comes to anything in life, and that's what we'd recommend.
Good advice. Yeah, Dr. Wilkinson.
I think just know that there are potentially other options besides implants. So ask to speak to your friendly plastic surgeon.
Dr. Deva?
Well, as I said in the last one, I think this is a really good example of collaboration. I think going forward we have a real desire amongst all the stakeholders here, patients, researchers, the regulator, colleagues, media, to ensure that, we all work together for a common cause, which is for the benefit of the patient.
Well, thank you very much, and thank you out there for watching and listening, and thank our panel for all their amazing information that they've imparted today. As I mentioned at the start of the webinar, this is being recorded. It will be put on the TGA website. It'll also be going out on social media. So if you're on social media, on Twitter or Instagram, if you want to follow me, which is at Sophie Scott and the number 2, I'll be posting out the links, or the TGA is another great resource. Again, also you can contact the Breast Cancer Network hotline for any specific questions that we may not have covered today. But thank you for watching.